Hello, everybody. Assalamu alaikum and hello, everybody. Uh, we are honored to have Dr. Rashid Sharaf as the guest speaker in our webinar. And Frank Rudolph will help me out here. He's part of the Byonyks team. He's one of the major players in terms of helping in the designing, mechanics, and all those things in the new generations of the cyclers. But before I start, I would just like to acknowledge that this meeting is not only Byonyks meeting, this is uh, acknowledged by Peritoneal Dialysis Academy of Pakistan, and Dr. Ahad Qiyum is the president, and by Pakistan Society of Nephrology. So we just forgot to put in the logo in our posters there. So, having said that, Dr. Rashid Sharaf is a big name in interventional nephrology. He is the chairperson currently and the next year for the International Society of Interventional Nephrologists in USA. And as we all know, that catheter is one of the major area where placing it and then, dealing with the troubles is one of the main concern for all the nephrologists and for the patients also. And this is sometime a big problem in terms of a success of any program. But I think as we are going along over the last couple of years and growing very speedily in Pakistan, we have seen uh, complications, but we have overcome those complications with the help of our mentors, such as Dr. Rashid and a few others who have been here, and even Dr. Crabtree had a lecture two or three times with us in the Peritoneal Dialysis Academy of Pakistan. And and we have seen that we can be successful in terms of the outcome in our patients. So what we'll do is, Dr. Rashid, you want to say a couple of words, and Frank, before we formally start. Dr.
Yeah,
Rashid?
if I interrupt here one second, sorry for interruption. One other things I want to say here is first, thank you for Dr. Rashid for joining the family of Bionics, and it's an honor for us to have you here. Absolutely, and I also want to introduce. I can see Dr. Salman Imtiaz, who is head of Indus here. Thank you, sir, for joining, and we also have Dr. Rohit Pinkhania. And I want to introduce Dr. Rohit and Dr. Noman and Dr. Rashid Sharaf. And I will take a little bit of context to Dr. Rohit Pankani is from Florida. He's the board member of Florida Kidney Physicians and many other organizations there. And he also joined Bionics family. And with Dr. Pinkhania, whatever knowledge we are spreading in Pakistan, like PD Academy of Pakistan and other activities, we have a plan to have very similar influence in Indian community in starting from Gujarat, Ahmedabad, and other places. And Dr. Pankania will be leading that. Dr. Pankania, before you get started, you want to say a few things?
It's almost good afternoon, past noon in Florida. Nice meeting you all. As Farooq introduced, Rohit Pankhania. I'm a nephrologist practicing in Florida since 2008. Got introduced to Bionics just a few months ago, and we were really impressed. And Farooq and myself have somewhat similar story about the patient for the specialty of nephrology. My uncle died waiting for proper dialysis. He was getting that manual exchange dialysis with 1 liter bottle. He will drive in a public transportation from Porbandar to Ahmedabad in 1985. And when I heard that peritoneal dialysis can be introduced in India, not that they don't do it, but right now is only for the rich people. The cost differential is so high. India has a system where government pays for all the dialysis. You can get twice a week dialysis for free in anywhere in India, including Gujarat. But PD is not something that is offered, and I found it very exciting. And one of my co-conspirator, Dr. Vishnu Patel, also from Gujarat, also had some vision that we can bring something back to the country of our origin. So we joined Byonyks team, and pretty much morning to evening, I think about Byonyk and what we can do, not only in USA, but also in India. Thank you for all your time. Thanks, Farooq.
Thank you. So our theme is kidneys do not have a flag, and kidneys beyond border kind of a mindset. So we need to spread this across the world. That's our passion. Back to Dr. Rashid. Thank you, sir. Sorry for the interruption. Go ahead, sir.
Yeah. Assalamu alaikum. Again, I'm extremely honored for this opportunity. I think from what Farooq has told me in the past, and you guys are an accomplished group of fellows over there. He could not stop saying nice things about you. And then, of course, there are.
I was trying to find if there's like a doorknob, but this is all we have is Acrobat with albuterol.
Someone, can you mute anybody else who is
The
not
doorknob is
talking?
both albuterol and Troin. Yeah.
Everybody else, can you please go on mute if you are not talking? Thank you.
Yeah, so I'm extremely honored. My perspective, I'm primarily an interventionalist, even though by training I'm a nephrologist. I'm primarily an interventionalist, and this is one of the things that I actually kind of helped develop the percutaneous PD catheter placement, and we modified the technique to a point where it is now so efficient and so easy to do. And now what I'm actually working on is just PD catheter placement, just using ultrasound guidance without even using fluoroscopy. So that is something that we are working on, and hopefully you will see a lot more bedside PD catheter placement with ultrasound alone in the future.
Great. Frank, would you mind to say a few words? Introduce yourself.
I'm currently here in the Chicago Research and Development Office, and if you take a look behind me in this somewhat chaotic space, this is where all the magic happens, and we're currently working on the next generations of our devices, which are going to be pretty revolutionary. Some of you have heard the details, and they'll be forthcoming to a greater extent soon. So it's a pleasure to be here with all of you esteemed ladies and gentlemen, and especially Dr. Rashid and Dr. Numan. Dr. Numan is very well known in the Byonyks community because he's been with us for a long time. I was one of Farooq's original founders of Byonyks, and as he tells me that I was the first person he called when he came up with the idea of starting Byonyks. So it's been an honor for me to be here for the last 7 years. Great. And I'm technically the chief electrical engineer. Right now I'm spending time looking at the new designs that we're working on, and those are coming along pretty quickly, faster than I had originally expected. So that's about all I have to say. So I'd like to turn this back over to Dr. Rashid.
Great. So what I'll do is I'll just share the slides. Someone, can I share the slides or?
You should be able to. There's no restriction.
Okay.
Yes, sir, please share.
So you can.
Yes, we can see.
Okay, great. So this is the there are like three cases, two cases and one question, one from Dr. Abdurrahman from Islamabad. So we'll be discussing these. So going quickly through these, this is our patient with autosomal dominant polycystic kidney disease, big kidneys in the abdomen, female, about 50 years of age. And she had a good urine output. She went into ESRD. And 1st May 2024, we put in the PD catheter. So APD was started later on, 5 days per week. It was going fine. There were no issues. The volume that she could tolerate was somewhere around 1,000 to 1,300 ml. And till December 2024, last year in December, she had some constipation issues and some flows issues. So we managed these. Let me see. Yeah. So this is the 3rd of December 2024. As you can see the slide, and here the drain time for the 5 cycles, about 1000 ml, is like 22 minutes, 16 minutes, 31, 25, and 28. So I mean, pretty okay drain time. So this was fine in the 3rd of December. So this is the summary that we get from our APD cycler, Byonyks cycler. This is the X1. And then, yes, on the 5th December, as you can see, there is some increase in the drain time here. 43 minutes initial, then, kind of okay, 33 minutes. And on the 9th December, so we have almost going into like 60 minutes, 53 and 54. So, but this was her um, X-ray. As you can see, there was some stool and gases there. So we tried CAPD, we flushed all the stool, and that was all fine. But with the CAPD, she had a fill time was okay, a few minutes, but drain was quite prolonged. So, Dr. Rashid, you want to add something here, or just to comment or something?
So again, one of the first things that I'm sure everybody is aware on this panel, that constipation is definitely not our friend. And one of the things that I do, even immediately after placing the catheter, is I send these patients home on some kind of laxative. My laxative of choice is lactulose, but any laxative that works in any patient should be used. And we actually, in my subgroup of patients, I will keep them on a dose of lactulose maybe 2 to 3 times a week. That even if they get a few loose bowel movements 2 to 3 times a week, I'm perfectly okay with that as long as they don't back up. But looking at the KUB, the PD catheter seems to be sitting in the mid to lower pelvis area. It seems well positioned. I don't see any kink in the catheter. So just looking at this, constipation seems to be the issue, but I think there's more to the story.
Okay, great. So then we ultimately went for um catheter evaluation under laparoscopy. So there was an omental wrap there. And so we inserted a new catheter, and somehow at the time we had requested for omentectomy or omentopexy, but it was not done. And so we were left with the same catheter, the new catheter on the other side, and we restarted the APD after a few days on the 6th of January. Now, till 20th of January, 20th of January, again, she had an episode of a failed therapy with a prolonged drain time. And before 20th, all the therapies were quite fine with the good drainage and inflow and outflow with successful therapies there. On the 21st, again, we have this X-ray. So just, ignore this flower here. This was a button which was, and the quality of the X-ray is not that great. I can't see the X-ray itself, but Dr. Rashid, if you would like to comment on the X-ray here.
Yeah, again, the patient seems to be backed up
Hmm.
here too.
So there's a lot of stool there
A
still.
lot of stool, yeah.
So as you said, constipation is is an enemy for us. Uh, so on the 9th of February, so we got the stools relieved, and she was fine. And you can see here on the 9th of February, so after a couple of days now, a few therapies done, and the drain time is quite well, 22 minutes, 18 minutes, 15 minutes, and 30 minutes the last one, but otherwise fine. So she was quite happy. And on the 9th of February, therapy was fine, as I just showed you. 10th was her day off, so she was on like 2 days off per week. But 11th of February, when she was going to start, she again felt some constipation and abdominal pain. So we had her evaluated, and this is her X-ray on the 11th of February. So this is almost like a second episode of constipation and gases. Dr. Rashid, your
Yeah,
comments?
again, it's more of the same. Again, the
Yeah.
catheter looks well placed, it's well positioned. Um, but again, you see a lot of stool, especially on the left side of the abdomen.
Mm. Yeah. Yes. So we had sent, the fluid also. Unfortunately, we found there were some WBCs there now. So we ended up having a peritonitis. So she is on antibiotics now. And most likely the cause of the peritonitis is the persistent constipation there. So most likely a transmigration of bacteria inside the peritoneal cavity. Now, just a question. If we see a recurrent infection like the, I mean, constipation like this, um, is there any role of any prophylactic antibiotics or no?
I mean, there's definitely a role for prophylactic laxatives, which I routinely use, which I mentioned earlier as well, that I routinely use prophylactic laxatives. But the role for prophylactic antibiotics, I don't think there is. I have now constipation, besides giving rise to transmigration with bacteria, uh, patients who are constipated, they also produce a lot of fibrin.
Mm,
Um, and you can get fibrin plugs, you can get catheter malfunction because of that. And in those patients, what I'll typically do is at the end of the treatment, usually pack the abdominal cavity with like a few thousand units of heparin,
mm,
just so that that fibrin does not actually plug things up. But again, without relieving this constipation, without making sure that she does not get constipated, this will be an ongoing problem.
mm. And the heparin, you just put it in, even if you don't have any kind of fibrins visible there.
Yes, yes.
Okay.
Again, yeah, because you know the next thing that's going to happen is if she's having transmigration of bacteria and she's developing peritonitis, there's definitely leakage of proteins, and those proteins they coalesce and end up with end up in the form of plugs over there.
Okay, so that's a great learning point. That if there is a continuous constipation or the patient is not getting relief of the constipation, even like her, we have given multiple times laxatives, even on the 11th and before that. But somehow, maybe because of her ADPKD, she has this diverticulosis or something like that. Maybe she has a tendency to develop constipation very easily and does not respond to even to the laxative. Or maybe sometimes the patient does not want to go to the washroom that frequently. They think that they have passed the stool, and but actually they may be piling up all the stool there. So in these cases, I think we should throw in the heparin as we do, like zero point 0.4 cc in a 2-liter bag, and there are like 2,000 units of heparin in a 2-liter bag. So that's great. So that's a great learning point here. So unfortunately, she's currently undergoing antibiotic treatment, and the culture came out to be negative so far. And but hopefully she'll be back on APD, and her CAPD is going fine, and her outflow has seemed to be improved. So I'm just going to quickly talk about the second patient, which is like 56 years old male, end-stage renal disease due to diabetes and hypertension. And his catheter was inserted on 24th October last year. And his APD was started after about 2 weeks. And this was his catheter insertion. It was placed laparoscopically. As we can see here, this is his catheter on the left side. And this was on the day of the placement of the PD catheter. So he had end drain pain with CAPD when we started it, And so we had to slow down the drain when it comes, towards the end. So, but with the APD, he still had the pain, but it was slightly less. Uh, this is on the 2nd of December. As you can see, his drain time is like 20 minutes each cycle, 1800 ml, and 33 minutes, 33 minutes, and which was kind of okay. And this is on the 2nd of February, recently. So 27 minutes, 33 minutes, 44 minutes, slightly increased, but functioning fine. If you can see here, the drain time is like 80, drain flow rate, 86 ml per minute, 58 ml and 61. And here it is 77, 66 and 45, which is like slower drain. And this is because, in the Byonyks APD cycler, we have different modes of pressures that we can provide to the patient if they have a drain pain. And luckily with this, there is one push mode that gives you the highest amount of pull. And then we have the normal, where most of the patients can tolerate. And then we have one with the comfort mode and one with the safe mode, which is like very low, almost like 8 kPa of pressure. So with these kind of changes, this patient, was feeling a little bit of pain, but it decreased to such an extent that even he could sleep through the drain at night with the APD cycler. So there was a lot of improvement in terms of the pain, but still it was, there. So his drain pain was, as I said, less with the safe mode, even can sleep through it. But now recently, what we found out that he has increased drain time. So about 70 minutes, 60 minutes, and 40 minutes. As you can see here, 2000 here, and this is his drain flow rate with the safe mode, and still there. This is the 14th February, 63 and 49, and quite a significant amount of time there. And this is his recent X-ray that was just done today. So this is the catheter, as we can see here, and this is the gut. And Dr. Rashid, your comments.
Again, I don't see any kind of a kink or anything. The catheter is well placed in the mid to lower pelvis area. Again, it's not a very sharp KUB, but I can see a lot of stool and almost some air in there, but a lot of stool.
So we have several questions that have come in from the audience. If you could entertain those now, I'll read them for you. One of the questions was related to one of the patients you spoke about earlier. The question was, you infused her with heparin daily?
Yeah, just a small dose of heparin. Typically with the last fill. So, the way we run our cyclers, and I don't know how the treatment is. I'm sure it must be pretty similar. The way we run our cycler is the patient will get multiple exchanges at night, and then there would be a last fill that the patient will carry that fill through the day and have either a midday exchange or carry it till the evening when they go back on the cycler. So typically with the last fill, the last bag that goes in, the heparin is in that bag,
Okay.
or we'll give it as a bolus at the very end. Typically, or routinely, I try to avoid having the patient manipulate too many things or give themselves boluses or those kind of things. So just a few thousand units of heparin in the last fill, that takes care of that.
Okay, thank you. Another question was that what is the let's see, I lost it. What's the criteria to select the best PD catheter for the best trouble-free PD?
Oh gosh, that's a question that I don't think anybody has been able to answer. Um, there have been so many studies that have looked at different kinds of catheter, whether it's straight, swan neck, coiled with a pigtail in there, all different kinds of catheters. And so far, no one catheter has been shown to be superior to another. Now, having said that, at ASDEN this year, I don't know if you know Dr. Stephen Ash. He has invented a number of things, and including the Ash catheters, and he actually has come up with the idea of, uh, it- you know, uh, the PD catheters. They have multiple fenestrations towards the end of the catheter where the fluid actually drains from or fills from. Instead of fenestrations, he's actually got um, slits all along the sides of the catheter. And he says, according to the studies that he's conducted, and so far there's no publication yet, but the data that he presented was that this actually helps to drain better. And even with omental encasement or entrapment, the catheter still continues to function well because there are other areas where the slit is still patent. So the answer is I don't know. I don't know the answer. Sorry, long-winded way of saying that.
And it sounded like a big question to start with.
Yeah.
We have a follow-up about the heparin doses, and the question there was, is the heparin, would those doses be indefinite?
Well, as long as the patient is constipated, I think once you fix the constipation, um, and I think it would be a good idea for the patient to be on, a slightly higher dose of whatever laxative you're using on days that the patients are home. If they are going to be out and about, like Dr. Tarif said, that they will skip their doses of laxatives. But the days that they are home, I I ask them to try and have at least 2 to 3 good bowel movements those days that they are home. So as
Now,
long as they're constipated, heparin should be given, I think.
I see. But another follow-up question was, would that not increase infection risk?
Because the heparin, absolutely, absolutely. Like I mentioned earlier, I definitely do not like the patients, handling their catheters or their bags too much. But at the same time, if they are making fibrin, if there is presence of that, then you're looking at fibrin plugs and multiple other procedures to get those things fixed. So you just have to weigh the risks and the benefits over there.
Okay, we have a question that's a follow-up about when a catheter was reinserted on the right side due to an omental warp. Uh, why did the surgeon during laparoscopic surgery not remove the omental wrap and make the same catheter functional?
So, I mean, Dr. Rashid, you can comment on, the need of omentopexy and omentectomy. How much?
So, again, I'm going to speak now I'm going to put on my interventionalist hat and speak from that perspective. What I have noticed is I generally, in a 62 centimeter catheter, we get almost about 15 centimeter of catheter length within the abdominal space. And I've noticed that if my catheters, I usually under fluoroscopy, under X-ray, I'll measure the distance from the symphysis pubis and try and make my entry point about 15 centimeters above the symphysis pubis. And I found that to be the happy medium, because one of the problems that I was having when I was placing my catheters in the deep pelvis was problems with drain pain. And then, I went the other way and I started placing my catheters a little bit too high. And then I was having problems with omental wraps. Now, what I do is at the 15 centimeter mark, I've noticed that that has the least chance of having any kind of, or it still is there, but least chance of having complications. And if I place the catheter over there, I don't even need to perform an omentopexy, which will require laparoscopy and much more major surgery with general anesthesia and CO2 insufflation and all that. So in order to avoid that, and I have not had patients come back to me with catheter problems or mental wraps as frequently. They still do, but not as frequently.
Excellent.
But we have
So,
another question here that
please.
asks, what should the threshold time for drain be? And in that same context, is the geometry of the catheter the most important cause here, or is it the position of the patient?
Dr. Tharif, I'll let you take that question.
Well, I can't say much, in front of you. The question is, about the catheter, its placement, as you already mentioned, 15 centimeters from the symphysis pubis. So it should take care of most of the geometry within the abdominal cavity and should be a fine area to place the catheter there. So that brings us to the next case and similar question about the catheter placement from Dr. Malik Abdurrahman from PIMS, Islamabad. And his question is, need to ask whether the percutaneous catheter can be attempted or we need to do a laparoscopic insertion in this patient with a pendulous abdomen, and otherwise she is not an obese per se. So this is the abdominal picture and your comments. And I see if Dr. Abdurrahman is here, so he can add up to that as per his will. No issues.
So,
Yes, I'm here.
Okay,
Sorry
good.
to interrupt, sir. So I was actually going to pass catheter to this patient on the Sunday, that's tomorrow. So, and I just got to know about this webinar. So I was discussing with Dr. Numan, and we had a thought that why not discuss this patient in today's meeting. So this patient, we actually want to start APD for this patient, and we are planning a percutaneous catheter. So when I examined this patient, I had two problems. Now, one of them was that I was not able to find the inferior epigastric artery on the ultrasound, and secondly, her abdomen is really pendulous. It's not that like she's very obese, but this is like sort of a pendulous abdomen. And I was really concerned about the fact that would there be issues if I'll go percutaneously, and should I go with the laparoscopic approach? So these are my questions actually.
okay. Thank you so much for your question, Dr. Rahman. Actually, the answer is very simple. Most of these kind of abdomens, if you actually scan the abdomen with an ultrasound probe, and I mean, just as a side note, I'm sure when you were looking for the inferior epigastric artery, you were probably using an ultrasound probe. I will typically use just a vascular probe rather than an abdominal probe to scan these, or for PD catheter placement, not just for scanning. You get a much better resolution with the vascular probe, but that's just a side note. Most of these patients, if you look at them, their abdomen, they tend to be they're obese, but the thickness of the abdominal wall, and when I say the thickness, I'm looking at from the skin to the posterior rectus sheath, is generally less than 4 to 5 centimeters. And if it is less than that, you can easily go with a micropuncture needle and enter into the peritoneal space. Having said that, I mean, I have put in PD catheters percutaneously or fluoroscopically in abdominal walls that are about 10, 12 centimeters thick in patients with BMI of about 45, even 50. And these are patients that you just have to plan it better. You just have to change the resolution of your ultrasound probe, but you can easily get in there into the abdominal space without having to use laparoscopy. So my answer is go for percutaneous rather than laparoscopy. Now, inferior epigastric, if I don't see the inferior epigastric artery, it usually tends to travel in the middle of the rectus muscle. So if I cannot visualize it, I'll use either the medial border of the muscle or the lateral border of the muscle. And more often than not, it's the lateral border of the muscle that tends to be the more avascular space. And if you still are not comfortable with that and you think that there might be a vessel over there, just go for the midline. The linea is definitely the most avascular of spaces. You might have to wait a little bit longer for the catheter to heal in, and maybe 2 weeks of wait period from the placement to initiation of dialysis. But you cannot go wrong over there either. I
So
hope that
the
answers
bottom
the
line,
question.
great. So what I get is that if you can't see the epigastric artery, inferior epigastric artery, so you go for the lateral border, or if you want to go more safe, then you go in the midline, the linea alba and avascular areas.
Yes, yes.
Great. I hope that helps, Dr. Abdurrahman, and wish you well.
Yes, sir. Just a very small question at the end. That I actually do this with a surgeon, and my surgeon told me that there is a point between the iliac spine and the umbilicus, and that point is where there are no tributaries of the inferior epigastric or the epigastric itself. So can I use that point as well, which is like a straight line? If I draw a straight line from the iliac spine and the umbilicus and the midpoint between
Meeting now?
You sure can. Having said that, the umbilicus is not a very good landmark. And if you place enough PD catheters, you will notice that some folks have their belly button ride very low. Some people have their belly buttons that ride super high. So it's not a very constant landmark. The other problem is if you're starting from the iliac spine, or if you're close to the iliac spine, you're looking at placing the PD catheter very low in the abdomen. That means that your catheter is going to be kind of deep. That also means that your chances of having drain pain or entanglement down there would be more. So that is an issue, but that's not always an issue. If you think that's a good space, go for it. Surgeons typically tend to go very low, and that's one of my problems with surgically placed catheters is that they come back, or those patients tend to have a lot more drain pain than the percutaneously placed ones.
So the point should be 15 centimeters above the symphysis pubis,
Symphysis
right?
pubis, yeah.
The safest area and the best area with
Yeah.
all the experience that you have gained.
Yeah, and
Great.
this is honestly something that I learned from my own mistakes or from trial and error, to be honest.
Great.
Let me.
So Frank, do we have any one or two questions? And we can go on. Go ahead, Dr.
Yes,
Rashid.
let's see. One of the questions was the first patient that you disclosed to us was she on a cycler or on CAPD?
Both of them were on cycler.
Okay. And what interventional approaches are preferred for recurrent catheter-related outflow failure?
Will that be a part of your presentation?
I'm sorry, I didn't quite follow the question. What kind of measures for recurrent outflow failure?
Exactly.
Yes.
We can definitely touch upon it later on. It's
So
there.
I think we can wrap the discussion here, and I'll let Dr. Rashid I'll stop sharing, and Dr. Rashid, you can just take from here, please. You can share your presentation.
Can you see my screen?
Yes, please.
Okay. Actually, I think and this is my fault. I didn't really pay attention to the topic that you guys had given me and prepared a talk that was a little bit more extensive. So I'm going to quickly go through this, and I'll focus a little bit more about what we do. This is my practice. This is Star Vascular Access Center. We primarily take care of end-stage renal disease patients. Most of my work is actually vascular access, starting from creating percutaneous fistulas to maintenance, and PD catheter placement. So anything RD where they require any kind of support for the dialysis, that's what we do. This is my passion. This is my hobby. I love to fly. Anytime I'm not working, this is what I'm doing. Now, the abdominal space, and this is a ChatGPT created abdominal space, so you will have to forgive it. It's got so many weird things. But the point that I wanted to make was that if you were to rip out the anterior abdominal wall, the catheter sits right beneath, or a good catheter should be sitting right beneath the anterior abdominal wall. And I don't know if you can see my mouse. It should be sitting, can you see my cursor over here? Or my mouth? Yeah. A good catheter should be sitting somewhere in this region, right over here, in the rectovesicles area or space. The other name for that would be the Douglas pouch. Or okay, so yeah. Now, this is what I was talking about when I was talking about the distance from the skin to the posterior rectus sheath. You have your skin, your adipose tissue, the anterior rectus sheath, the rectus muscle. This is where you will typically find the inferior epigastric that runs up and down the posterior part of the rectus muscle, and sometimes we'll actually get into it. But having said that, the inferior epigastric artery, even if you miss it, you could sometimes hit some of the branches of the inferior epigastric artery. So you have to be super careful when you're doing that. And then the abdominal structures which sit within this cavity. So one of the things that we do with ultrasound is to make sure that all of these structures are free from the posterior abdominal wall and that they are moving freely by asking the patient to breathe in and out. And we should be able to see all the organs slide under the peritoneal surface. This is how the catheter actually goes in from the skin. You will typically have a tunnel. So you will have your superficial cuff, the tunnel, the deep cuff, which either sits within the rectus muscle, but in my case, what I will do is I'll leave the cuff kind of in the adipose tissue over here. So it's not only easy to place, but it's also easy to pull out as well. The other thing is this is your omentum. The omentum typically tends to be in the cephalic part of the abdomen, and as it senses an irritation, as it senses a foreign body, it will migrate to where the catheter is and try to encase that. And the bowel loops, whether these are small bowel, they will all sit kind of deep to that or posterior to that. This is a well-placed PD catheter. It's kind of in the left pelvic area. It's deep, and you can see the contrast flowing well into the pouch over there. So with that, I have a case. It's a African-American female in her 60s, presented with drain pain while on CCPD towards the end of the drain cycle. The patient was asymptomatic on CAPD. So the way we typically train our patients is we'll train them on CAPD and then switch them over to continuous cycler once they have been trained. She has been on PD for about 3 months now, diabetic, hypertensive, coronary artery disease. The PD catheter itself looks pretty unremarkable. So I know this is a very busy slide, but this is kind of the algorithm that I pulled out that you can use that can be helpful in coming to a decision. You don't have to do all of these things. I think Dr. Tarif pointed out and the point that he made with the cases that he presented is that think constipation first whenever there's any kind of drain failure. So when it comes to peritoneal dialysis or PD catheter failure, There could be early complications or early problems versus late problems. The early problems would be bowel perforation or bleeding associated with the surgery itself, wound infection from the newly placed catheter, outflow failure because of clots or fibrin, or a kink in the tunnel because the interventionalist or the surgeon did not do the job properly of straightening out the tunnel. Omental wraps, adhesions, migration of the catheter, or misplacement where you did not place the catheter in the right place in the first time around, or dialysate leak. In some cases, if you start using the catheter too early and the seal has not formed, you can get dialysis leak. And of course, peritonitis, which could be iatrogenic. In late cases, it's usually like exit site infections, tunnel infections, cuff protrusion, outflow failure because of constipation, dialysate leak with hernias, and obviously peritonitis can happen at any time. Please stop me if I'm going too fast, or if there are any questions. Dr. Rudolph, just stop me and we can go over the questions as well. Infectious complications, you can divide them into three: what's going on within the peritoneal space, what's happening at the exit site, and whatever in between. Peritonitis is obviously the most dreaded of all kinds of complications. It could be because of touch contamination. It could extend from the tunnel or the exit site, or come from an intra-abdominal source, like Dr. Tarif pointed out, whether it's constipation or a bowel perforation, diverticulitis, or very rarely, and I've never seen this, to be honest, hematogenous spread from the blood itself. This is how you diagnose it. I don't think I need to tell anybody. The only point I would like to make is if you have a fungal Staph aureus, especially MRSA infections, or Pseudomonas, these organisms tend to be super sticky, and just antibiotic treatment alone is not enough, and you will typically end up replacing this catheter. This catheter will have to come out, and maybe even a peritoneal rest for some time. Again, I'm gonna skip this. This is a typical example of an exit site infection that happened fairly immediately after placement. This patient had some kind of an allergic reaction to the silicone tubing, and you can see right where we placed the catheter from. This is where the catheter actually went in from, and this is the exit site. There was some kind of an allergic reaction, and ultimately ended up getting infected. And the only thing we could do was remove this catheter. Now, having said that, I think the patient had some skin condition. This is from a previous laparotomy that the patient had. She had ended up with multiple scars. So the point that I wanted to make is that just because somebody has had multiple surgeries does not exclude that patient from being a good PD candidate. And you can do that percutaneously as well. You don't have to have a laparoscopy for that. Again, I'm going to just skip through this. Tunnel infection, usually I'll say this happens right where the deep cuff is. And this is an abscess right where the deep cuff was supposed to be, or where the deep cuff is sitting. And this had been treated by the nephrologist about 3 or 4 times. The patient would get an abscess, and they would treat with an antibiotic. It would get better, and then a few weeks later, the abscess would form again. So we initially drained out the abscess, or the nephrologist had the abscess drained out. When I saw the patient, the infection was getting better. But honestly, the best treatment is catheter removal or resiting the catheter. I'll usually remove the catheter and place a new one right at the same time. Now, mechanical complications that can happen with catheters are catheter migration, mispositioning. The mispositioning will usually happen at the time of placement because of the catheter being either too high or or too deep. And this is especially true for percutaneously placed catheter. You cannot really control in most cases where the wire goes or where you can place the catheter. And even after you place the catheter, sometimes it will flip because of the angle that you're placing it at. So one of the things that I did not mention is something called rectus sheath tunneling. That's one of the things that I do to make sure that my catheter remains pointing downwards and does not get mispositioned at the time of placement. But migration typically will happen because of omental encasement, and the omentum will pull it in one direction or another. Usually it's towards the right upper quadrant. Bowel perforation, bladder perforation, hernias that can happen, and you should always keep in mind hiatal hernias. That will also get worse as you start the patient on dialysis and as you start increasing the intra-abdominal pressure with your fluid. Abdominal compartment syndromes have to be kept in mind as well. I've only seen one case in my career so far of abdominal compartment syndrome, but obviously the patient had to come off PD. Dialysate leaks can happen, especially if patients there are certain patients who tend to heal slowly, and in those cases the leaks will happen, but you either have to back off, reduce the volume, or just stop PD for a short period of time until it seals. Catheter clots and plugs, I think we talked about it extensively earlier already. And also keep in mind diaphragmatic leaks. These are things that we'll only discover, or holes in the diaphragm we'll only discover once we start the patient on PD and they present to you weeks, months. I've had, in fact, patients who have presented years later with pleural effusions. And then you realize that they actually had diaphragmatic leak that was slowly accumulating, and it got to a point where it started to clinically compromise the patient.
So the diaphragmatic leak does not happen right away, or it can develop at any time during the PD.
So the leak or the hole in the diaphragm was probably there to begin with, but it may just have gotten bigger, or even the diaphragm sometimes will serve as a one-way valve. It will allow the fluid to go into the pleural space, but not vice versa. So once it goes there, it just keeps accumulating over time, and and the patient will ultimately present with pleural effusion and shortness of breath. This I thought was a very helpful, quick guide. I found it on UpToDate. But depending on whether it's an outflow or an inflow problem, what it could be. And if it's early, catheter kinking, malposition, all of these are outflow problems, but kinking could definitely cause inflow issues as well. Entrapment, I've seen an inflow problem with omental entrapment or adhesions. So it's not just an outflow thing. But you will see that pretty much any kind of catheter-related problem will cause an outflow problem. Not so much of an inflow thing, whether it's pain or slow drain. This is again a very you guys can look at look at it in UpToDate, a nice algorithm to go down to see what to do, when to refer, how to treat these patients, and I'm not gonna get into this at this point in time. Catheter malpositioning or mispositioning occurs when the catheter tips moves out of the true pelvis, leading to poor drain. Now, one thing to understand is that 90% of our ionic exchange happens within the pelvis and the two paracolic gutters on each side. So between these three areas, in this U-shaped area in our body, is where 90% of the ionic exchanges is happening. The rest of the peritoneal surfaces, whether it's the parietal or the uh, visceral peritoneum, it accounts only for 10%. So even if the patient has adhesions in the mid-abdominal area or the upper abdominal area, these patients can still be good candidates for PD. And that's the only thing that I'll keep harping, because especially here in the US, once the way the nephrologists have been trained up until now is that the moment they will see 1 or 2 or 3 surgical scars, they will say, oh, he's not a candidate, and they will not even refer the patient. The most important thing to understand is that these patients can still be good candidates. With the mispositioning or malpositioning, you can have, it could also be because of bowel distension, constipation itself. A hard constipated colon will push the catheter one way or the other. The presence of adhesions, improper placement, increase intra-abdominal pressure from constipation or obesity will move the catheter. And of course, the most feared of all things, or the least responsive to therapy, is omental wrapping, which will require some kind of a surgical revision of the catheter. Inflow failure, the fluid may not go in easy, will definitely not come out easy, and pain during exchanges will be some of the signs of mispositioning of the catheter. And I've had a lot of patients who come in with the catheter somehow migrating to under the liver capsule, and they will come with right upper quadrant failure, almost mimicking cholecystitis. So the management obviously is repositioning. Percutaneous repositioning honestly does not work well. Most of the time, when I say percutaneous, I'm talking about fluoroscopic positioning does not really work well. Laparoscopic repositioning and surgical correction, freeing up the catheter from the omental wrap, and then omentopexy is the way to go. Now, having said that, one of the things that I do is, because I said a fluoroscopic repositioning does not work, what I'll do is I'll just pull the old catheter out and put a new catheter in from a different entry point and a different position. And somehow or the other, the momentum appears to be wrapped around itself, or whatever the case might be. If you place the catheter in a different part, it will work, and it works well. So in most cases, we don't have to refer the patient for an open surgical correction. Bowel perforation is obviously a major concern. I have seen cases where during placement, especially whether it's percutaneously or laparoscopically, the patient have had their bowel perved inadvertently, they will require repair, oversewing, and they might even require some rest before they can go back on PD. Having said that, one of the techniques that we developed for PD catheter placement is using a very small needle, like a 21 gauge needle, to get into the peritoneal space. So even if we accidentally puncture the bowel, all I have to do is pull the needle back and replace it in a different position. And I have not had any kind of peritonitis because of that. We will give them antibiotic coverage for that. These are some examples of bowel perforation. I'm sorry, these x-rays are not the best. But here, you will see there is a kind of a linear collection of contrast. This is contrast that's actually going into the periperitoneal area. So this is the space between the posterior rectus sheath and the peritoneum. So you see the contrast kind of collect over there. Here in B, what the surgeon has done is that the needle has gone through and through. So there's a collection of contrast within the bowel, but then the contrast is also spreading in the rest of the peritoneal space. So if you are not careful and you're not paying attention to this, you will think that you're in a good space and you will place the PD catheter, not realizing that you're actually going through the transverse colon's wall over there. And this is a clear-cut picture of injury within the bowel itself. So just the needle itself is okay, but once you dilate and you start placing your catheter, that's when you have torn the viscera over there, and that will have to be surgically repaired. Hernias, umbilical, inguinal, or incisional, it's primarily because of increased abdominal pressure that can lead to hernias. Now, having said that, especially umbilical hernias that the patient may have had since their childhood, if it's usually less than 10 millimeters in size, I don't know if in Pakistan they still have Athane, but that would be about the size of Athane. If it's less than that, I will not pay any attention to it. I'll go ahead and do the PD catheter, explain to the patient that they might get an eversion of the umbilicus, but that's okay as long as it doesn't increase in size. Obesity, prior hernia surgeries, chronic cough or straining, these are some of the risk factors. Now, having said that, anytime we send the patients for repair of hernia, we always will ask them to place a mesh to repair the hernia, because the mesh will provide proper strength to the anterior abdominal wall or the inguinal area. Otherwise, if it's just suturing the abdominal wall or the hernia in the inguinal area, that will come apart again. Patients with chronic cough or straining, I don't think I need to dwell too much on the signs or anything. So dialysate leaks, that can cause that can be a problem with the drain as well, especially for newly placed catheters, or these could also be a sign of a hernia that has developed around the catheter track. So sometimes the peritoneum, which may have encased and sealed the catheter over there, can develop a hernia over there, and you can develop leaks. So these are things to watch out for. But more often than not, these represent or these happen with newly placed catheters that are used. And so one of the ways to mitigate that is for new placed catheters where we have to start dialysis urgently, I'll ask for low volumes. I'll tell the staff that two things that I ask for. One is make sure that the patient is supine. Do not leave the patient wet during the daytime when they might be going around doing things, picking up their babies or picking up boxes or whatever. Do not leave the PD fluid in the abdomen. Anytime they're doing any kind of exchanges, they should be supine. The other thing is that when possible, give it enough time to heal up.
Gentlemen, we're reaching the end of our allotted time here, I think. And
Yes.
I'm looking at these last questions, and some of these questions are pretty big questions.
Sure,
But,
let's go ahead and do the questions.
Yeah, so let me just touch on the last of the questions that we've got here. And the first one that I see here is, what interventional approaches are preferred for recurrent catheter-related outflow failure? That sounds to me like a question whose answer would be very extensive, but feel free to take a stab at it.
So, so I think the most important thing when it comes to recurrent failure is, again, the thing that Dr. Tarif and myself have been harping on: constipation, constipation, constipation. That is the number one cause of recurrent failure. The other thing that then you need to consider is whether when you place the catheter in the first place, did the patient have a lot of adhesions, a lot of scar tissue within the peritoneal space? You might have to ask the surgeon to go back and do some adhesionolysis or omentopexy. But I think constipation by far would be our worst enemy.
One quick
No,
question, Dr. Rashid, Frank, if you allow me. You said you place the catheter in the subcutaneous fat rather than within the rectus muscle itself.
The
Is that
deep cuff.
right?
Yes.
So the deep cuff. So but does it take an extra amount of time for it to heal and fibrose compared to being in the within the rectus muscle itself?
You know, we have thought that that would be the case, and we actually did a study ourselves and found that the time to heal was no more than surgically placed or where the cuff had been implanted within the muscle. And
Mhm.
our start rates, most of my catheters, once we place them, are started within 48 hours. And that by definition is an urgent start PD. And our leak rate is less than 1%.
Great.
now here's a question that is almost a religious question. Is PD better than hemodialysis? And what's the difference between the quality of life between the two modalities? I know that there are a lot of differing views on this, but again, feel free to take a quick stab at it.
Do you want to do that? Do you want me to? Again, I'll probably be able to speak from the US perspective, but I think Dr. Tarif would probably be able to speak from the Pakistani perspective better.
Well, I mean, we're not saying, that every patient who is a dialysis patient should be on PD. Yes, I mean, if you talk to Dr. John Bagman, she would say, every patient has to go on PT before has to go on hemodialysis. And this is the case in many countries as a PD first policy. So the PD is quite okay to start with. It is better quality of life. It is better survival initial years compared to the hemodialysis. But some patients may have their own perspective in terms of logistic other things. They would like to go for hemodialysis. So both modalities are there. The quality of life is much better, documented again and again with peritoneal dialysis compared to the hemodialysis. Dr. Rashid.
100%, 100%. 20 years ago when I started my practice over here in San Antonio, uh, uh, I was trying to buck the trend, and I would not even offer hemodialysis to my patients. Uh, you know, truly and honestly, I was supposed to give them both options that, hey, this is PD, this is hemo. But at that time, PD was not fashionable. So what I used to do was just say that, hey, this is what you're going to do. I think it gives them an opportunity to remain mobile, do the things that they love to do, whether it's work, whether it's spending time with the family. I think it just gives them that better quality of life. But then I think my view is biased, but you can look at so many studies that actually show that.
And in that same, context, here's a question that focuses just on PD, and it's about transitioning from CAPD to APD. So how is APD more safe? We'll talk about its adequacy and its effectiveness, its cost effectiveness when shifting from CAPD to APD. Any comments?
I'll let you pick that one, Dr. Tarif.
Well, I mean, it all depends, again, if the patient would like to do 3 or 4 exchanges a day, that's fine. But it is much convenient, even in USA, 80% of the patients who are on CAPD or APD prefer to go on APD because at night you can just hook up yourself and do the PD overnight, and in the morning just disconnect and you're okay with that. So, and you have the whole day free, the quality of life and all these things probably much better than CAPD compared to the APD. And the cost itself, there are certain, the cost is borne by the government within the US and most of the countries. In Pakistan, it is not so right now, but people are struggling, and we are, with the help of the nephrology community, convincing the government and other the insurance companies just to make sure that to provide the APD also as one of the option for these patients.
And along those lines, right now, both one of the divisions of Byonyks and our partner nonprofit organization, Kidneys Without Borders, are trying to address the cost issue for Pakistani patients.
Yes, you're absolutely right. We have Dr. Hina Akbar, who is part of the Kidney Beyond Borders, and we have Dr. Maliha Johar, Dr. Rashina, and the people from Indus Hospital, Dr. Faiza and Salman. They all know that, we are all together in this and working to overcome the shortage in terms of the funding for these patients.
Hey, Frank, if I could interject, this is Rod Kenley.
Go for it.
Regarding the difference between hemo and PD, clearly the quality of life is better, but the one thing that has impressed me the most over the last nearly 50 years is the difference in intermittency versus continuous. With in-center hemodialysis, you've got very aggressive changes in the human physiology over 3.5 to 4 hours, 3 days a week. And the lack of homeostasis of this intermittency, to me, is the biggest difference between the two modalities, with hemodialysis being much inferior in that regard. It just really wrecks people's physiology. And for that reason, I would certainly put myself or my mother on PD long before in-center hemo.
Now, as I said before, we're kind of running out of time, and there are a number of questions here that probably are not going to get fully addressed. For those of you who have posted questions and still would like answers, if you could perhaps address those questions to me, and I will convey them to our guests. I'll post my email address on the chat, and so feel free to pass those questions on to me. But before I give up, there's one question that comes from one of our peoples, and so I'm going to jump the queue here and ask it because it's a question I'm interested in, and that is, when we're doing bench testing, and we want to address issues related to fibrin, the question is there a way to accurately mimic the fibrin that would be helpful in this context?
I don't think I can answer that. I'm not qualified to answer that.
Dr. Naman?
I didn't get. Can you just repeat it? Just
well,
typing.
We're doing experiments in the lab in Lahore, in which we want to investigate issues around fibrin. But
yes,
coming up with some fibrin is not, we don't really know where to go buy some fibrin. So could you talk to us about how there might be a way to mimic fibrin that is truly an accurate substitute for it in our experimentation?
I don't know the answer. I mean, this is a natural protein, and I don't know. We'll have to just get the weight by weight and these form and stuff. So I'm not sure. We'll have
Actually, Frank, I have the answer. We did develop a method for doing that back in the 1980s when we were developing the home choice cycler. So I can share that experience with you guys later.
Okay, sounds good. No surprise to me that Rod would come up with that. He has immense experience in this field.
Rod is the one who has been with PD all his life.
Exactly.
We're lucky that he's sharing his experience.
I think one last thing that I would like to address here is that there are questions around the omentum. From our perspective here at Byonyks, we're deeply involved with what happens on the the outside of the patient's abdominal wall. For us, we have a very simplistic notion of what goes on inside the abdomen. I have always envisioned the peritoneum as being just this sort of regular bag that wraps around it, everything. But there are all these folds that or that are involved with the omentum. And one of the comments that you made, I think, Dr. Rashid, you mentioned something about the omentum that led me to believe that the omentum is almost this intelligent organism that's going around looking for things to latch onto. Could you just clarify that a little bit? And in the same in that same addressing that same subject, one of the questions had to do with how it's mitigated. Is this typically done with open surgery or with laparoscopic surgery? And maybe what's the difference between an omentopexy and an omentectomy? Or is that the right term?
Yes. So, in fact, the picture that I have over here is actually an ultrasound image of a PD catheter with an omentum wrapped around it. And again, you don't really get to see these kind of images. I thought this was very interesting and a very nice image. So I just wanted to share that with you. Having said that, yes, omentum is a living organism that's looking for and trying to mitigate any kind of intra-abdominal infections or foreign bodies or whatever the case might be. So when you're doing an omentopexy, what you're doing is you're taking the redundant portion of the omentum and you're wrapping it on itself and tagging it usually to the upper abdominal wall. You're suturing it to the upper abdominal wall so it doesn't track down to where the PD catheter is, which is sitting in the pelvic area. Omentectomy, on the other hand, is actually removing a part of the omentum, which has already become very redundant, which has already become very big, and you are cutting it out, basically. So that is the key difference. Now, open surgery is never an answer. I'm a firm believer of that. It should be done laparoscopically, if ever it's done. But I'm also a firm believer that in most cases, you don't really need to do that. All you need to do is reposition where you are, and you can find always an open space where you can put a PD catheter in.
Well, gentlemen, thank you so much for all of this wonderful information to me and to many of our people in our enterprise. There's a lot of mystery inside the abdominal wall that we don't deal with very much. We've sort of got this notion that, oh, you just install a catheter and then we're going to go over here and work on this machine. But clearly there's a lot more going on inside there than certainly than I had envisioned prior to this presentation. Again, I am placing my email address in the chat, and if you want further information about questions that you had that have not been sufficiently addressed, just send me the question and I will pass it on. And gentlemen, thank you so much for your time. This has been very informative, and I, for one, found it to be fascinating.
Thank you very much, Dr. Rashid, Frank, and everybody. We have a lot of people here from all over Pakistan, and I'm really thankful for this excellent talk and discussion, and Frank raising very good questions there. Dr. Rashid,
thank you so much for this opportunity. I honestly, I really enjoyed it. I enjoyed the questions, and I enjoyed doing this talk. Thank you so much.
And we can't wait to see you here
Absolutely.
at Byonyks. So feel free to come visit us anytime. So I think, Dr. Numan, that we have reached the end of our session for today. You have any final comments?
No, I think we'll just say goodbye, and thank you very much, everybody. And we'll see you again with another exciting webinar soon.
Thank you.
Thank you so much.
Thank you.